Thank you, Telangana RSSDI, for having me here. So it's an honor to be here in this August audience and then talking amongst the endocrinologists and diabetologists about management of diabetes and MAFLD without drugs, which is something which is unusual. But I'll try to impress you in the next 15-20 minutes on what's happening in this field. So, in fact, the last couple of talks from C. Nagesh and down, so there is a change of economy and growth and a paradigm shift in the GDP of one country with the drugs what have been there in the last 2 years. That's Denmark, the Novo Nordisk. So if you see on the screen, there is a surge of pharma growth in 2021 and 2030 it's expected to be around $30 billion of economy which comes on these drugs. Every third, fourth month we have an article in the NEGM on these drugs. So that's how it is. And if you see the pre-COVID and post-COVID, these are three things which have become kind of a pandemic, the obesity, diabetes, and NAFLD, or of course the MAFLD, what we call now. I don't want to bore you again with all the 1.5 days of theory which has been in your minds. You're all the masters now on insulin resistance in this. I'll skip this. But primarily what I want you to focus on is the endoscopic restrictive therapy and metabolic therapy, which we as gastroenterologists or endoscopists do. Primarily what you have to know is there are two things which we do. One is at the stomach level, second at small intestine level. At stomach level, we will reduce the weight of the patient, which indirectly gives a positive effect on the metabolic parameters. Whereas in the small bowel, we directly affect on the metabolic parameters, which lead to indirectly the weight loss. So this is something which I quite often tell in many meetings, that it's no more the pancreas which is the metabolic center for control of metabolism, but it is the duodenum first part, which we as gastroenterologists are very fascinated with this. So what happens is you have the incretins and anti-incretins on the brush border of the small intestine. When you have a balanced meal, then there will be a balance between these two, which will lead to euglycemia. But obviously, must have had a sumptuous lunch with a good desserts. So when there is a disbalance between these incretins and anti-incretins, then comes the insulin resistance, which leads to all our metabolic parameters increase. So duodenum is the metabolic center where we are targeting, and that's where the enterochromaffin cells release multiple hormones, where all these drugs and even the endoscopic therapies are going to play on. So the disbalance between the one is which leads to this. Again, we all know the insulin resistance causing what all, that's again, you are all the masters in that. So two things what you have to remember is what we do. The foregut hypothesis is where we bypass the proximal small intestine, that is the duodenum, and then we will make the nutrients not to contact the mucosa, thereby preventing anti-incretin secretion. Whereas the hindgut hypothesis is we exclude the duodenum and proximal jejunum, that is what surgeons do in Roux-en-Y bypass, thereby stimulating the positive good incretin secretion. Bariatric surgery, we all know about, it's proved beyond evidence that it has got a good effect on obesity and metabolic therapy. And we have seen patients going off insulin or decrease in drastic insulin consumption when they are post-bypass surgeries. There are multiple trials, there are RCTs which have been published in the last 15-20 years. So this is a very interesting study which you all have to focus on. See, in a patient with obese and diabetes, the patient has been taken off all the anti-oral hypoglycemics, and then they have been fed with the normal diet, which led to hyperglycemia. So after doing the Roux-en-Y bypass, as you see on the screen, the same patient has been put on the normal feeding, where the food will pass on from the stomach directly into the jejunum, and the patient was having a normal glycemia. But when they have done a gastrostomy and then put in a tube through the stomach and then fed the patient, what they have seen is a surge in the hyperglycemic levels. That means if you bypass the small intestine, then you have the effect of getting into euglycemia, or rather the other way around, where they lead to hyperglycemia. So based on this hypothesis, we strongly believe that duodenum is the influential mechanism of nutrient passage. And if you see the lifestyle modification and your pharmacotherapy versus the bariatric surgery, there's a lot of vacuum or treatment gap. And that's where we as bariatric endoscopists have done a major paradigm shift in the last 1 decade on this. So what we do primarily at The small intestine level is the putting in some bypass liners or ablating the duodenal mucosa or putting in some anastomosis. So endobarrier is one which has been widely practiced and focused in the literature from past 10 years. In fact, 2008 they started this device which acts as a duodenojejunal bypass liner, and they have significant literature supporting that they went into euglycemia. The company has withdrawn with some amount of side effects in terms of liver abscess, but they are coming back with the evidence on this, and then probably it will soon hit the markets. So we at AAG started working on this with a similar device from Minneapolis, and then we did the same of duodenojejunal bypass liner, where we put this polyteflin coated sheath which will cover the first part of duodenum and then impedes the absorption of nutrients. And this is a very simple procedure done for 15 to 20 minutes, where we deploy this biflange stent and then take it out. And what you see is retrieval also is pretty much easy, hardly takes 5 to 10 minutes. And we have done good work on this. The first in human trials has been done in the AAG, and we found around 1.5 to 2% glycemic control. But it's not all as rosy as it is. We had some migration issues, so we went back to bedside and benchside, and then we are trying to solve the issues probably in the next 6 months to 1 year. This device also might hit the markets. Another interesting thing, which is again not very commonly practiced, is we place endoluminal magnets. These are like the Roux-en-Y bypass surgery, what surgeons do. There are two scopes which go from oral end and aboral end, and these two scopes will deploy the magnets, and these magnets will form a rent between the jejunum and ileal loops, thereby whatever food comes into the jejunum directly goes, which is called as ileal interposition or ileal bypass, what surgeons do. And this is a technique which is a non-surgical one. We have been found to have good results, but again, it's not in the market. The second thing which you all must have read in different books or in various conferences is duodenal mucosal resurfacing. That's going to be there in the next decade, because this is simple ablation of the duodenal mucosa by achieving the glycemic control. So this is again a OPD based procedure where a simple upper GI scope is taken, and then you ablate the duodenal mucosa with, I'll just skip the move a little bit fast because of want of time. And as you see here, the duodenal mucosa is ablated with simple hot water, and then you create artificial damage to the mucosa, but again it will heal in 3 months. So what happens in this is, as you see, this is a live case which has been performed. You just put in the catheter, inflate it, and then put in the hot water. As you see, the duodenal mucosa gets ablated, and after 3 months there will be a normal healing of the mucosa. Studies have been shown. There are pivotal trials, randomized controlled trials published in gut and very journals, where they have found significant improvement in the glycemic level and also improvement in the impaired fasting glucose. And as you see, all the metabolic parameters, including the cardiac, liver, and HOMA-IR and so on and so forth, have found significant improvement with this duodenal mucosal resurfacing. Even in patients with MAFLD or MASH, they have been found significant improvement in terms of liver biopsy parameters. So this is about the DMR. There are multiple trials, and as Dr. P. Virov pointed out, if you combine these newer GLP-1 analogs with these mechanisms, that will be having a dual effect of improvement of significant glycemic control and also as weight loss medications. So this is again the same study which has found that GLP-1 analogs with DMR has found profound improvement in the results compared to DMR alone. I'll just skip these slides. And the newer therapies which we are working on is the laser therapy, RFA, electroporation. So this is one which is recently introduced in US and Netherlands, where we go with the upper GI scope and then we ablate the duodenal mucosa with a duodenal mucosal resurfacing using electroporation, which is a more refined technique than the DMR what I have shown you earlier. So you push the catheter along with the scope guidance, and this catheter will give a 360 degrees ablation of the duodenal mucosa, which takes hardly around 15-20 minutes, and we start ablating the mucosa from second part of duodenum up to 10 to 15 centimeters. And this is how the live case has been done in one of the congresses in US in Mayo Clinic, which is a very simple technique. You hardly need any requirement for this. A simple normal upper GI scope and a conscious propofol sedation. The patient walks out on the same day. So this is the literature supporting this, which has been published in recent DDW 2023. So I'll just skip that also. So the conclusions of this duodenal mucosal resurfacing using electroporation is very promising. There are some pivotal trials which are going to happen in the next 6 months to 1 year with AAG as one of the centers in the world. And let's see how the results will come out on that. And this is again the same electroporation which is showing a complete healing of mucosa in 3 months. So even the MASH or MAFLD, which we are interested in, also showed significant improvement from baseline of liver fat percentage of 23 to 12 months. It has come down to 2.8%, which is a phenomenal improvement in terms of NASH and NAFLD parameters. So the ideal duodenal ablation technique should be a design which is through the scope, and it hardly takes 25-30 minutes without any fluoroscopy, done under OPD-based procedure as a conscious sedation. So this is what we are targeting, and I am sure in the next 2 to 3 years, we are going to come up with this as a commercial device in the market. And I am telling you, this is not a competition with any of the drugs, but it's going to be only a complementary with all the drugs existing. So the primary, in a nutshell, what these DJLBs do is they have a glycemic control, they have the weight loss, they also have the positive cardiometabolic improvement in all the parameters. In fact, this is one study from Hyderabad, our unit, where we have done the endoscopic sleeve gastroplasty, reduced the weight of patient by 10 to 12 kgs, found significant improvement in all these hepatic steatosis parameters. So what I mean to say is, the small intestine targeted therapies are the future, and they're going to be there for the next decade. If we accept it or not, they are there, and they have to be there as a complementary to all your drugs, what you use, with a lifestyle modification, of course. And again, all these things, what we do is not a single man show. It should be a multidisciplinary approach. Only then you will have fruitful results. In fact, we have an endocrinologist, Chandana, also here, Mohsin. So we all work together, and any patient who comes in should not be treated as in your own branch. If you know, I mean, you say you should not bump them with drugs, you should not force them to endoscopy, you should not force them to surgery. It should be a holistic approach where all of them work together and give the best outcome to the patient with minimum or no side effects. That should be the main crux of the story. So with this, we have a department back in AAG where we all work together in conjunction, very cohesively and very friendly manner. Thank you.
Thank you, Dr. Rakesh, for beautiful talk on endoscopic management of diabetes and NAFLD. Our next is speak. Any questions from the audience?
Yeah. DMR, yeah. No, it's reproducible. What studies have shown till now is there is glycemic control of 1.5 to 2% up to 1.5 to 2 years.
Okay.
After 2 years, we don't know, but our gut feeling is because it is a OPD-based procedure, we can redo it again. Because the mucosa is getting healed in 3 months and there is no damage as such to the human body.
How much would that cost? Can I ask?
Right now, it's not commercial, but we expect to be around, I can say around 40 to 50,000 probably,
That's
each
good.
sitting. We are trying to get it down to that level at the Indianized version of DMR.
Yeah. Thank you.
Thank you.
Wonderful. At this point, I would like to announce that if any of you would like to do your fibroscan done, the last 2-3 talks were on NASH.
Yeah.
So kindly go and check your liver health.
Yeah, with the
They are still
permission
there.
from Chair, I would add that in many of the conferences across the world, now the unique selling point for any of the persons from diabetology, endocrinology or gastroenterology is fatty liver. So in fact, that's one which is a silent killer, which in a long run will lead to, in fact, now we as hepatologists are seeing a rapid increase in HCC in patients with this cirrhosis due to NASH. So that's very alarming because Hep C, Hep B have come down. Now NASH is kind of giving 20 to 25% people going into HCC in a long run. So that's something which you have to cut down at the root level before it progresses. Thank you.
Thank you.
Thank you.
Our next speaker is Dr.